it's like, okay, there's 5 hours in there where you get some sleep. I mean, it's crazy. I mean, it's all good. I mean, it's all things that they need to be done, but still, it's just a lot of construction. For what I was told, it used to be very sleepy over there. Yeah.
There's a crane.
Yeah, and there have been times where, they'll tell you, okay, we have to park this in front of your driveway, you won't be able to, get in and out. So you just have to, like last summer, we couldn't get in and out. It was 2 weeks, so we literally like going to the grocery store with like a suitcase because you couldn't really unload anything near your house. So you're like, we put all your which is, I mean, I know it's all good, but it's just very tiresome.
You have a full day here, you're stressed, you want to go home, it's raining.
Maybe you can't get into your driveway.
At least there's light.
Hi, Dr. Messina.
Hi, hey, hello everybody.
Do you know Mahama Ali, doctor for the cancer?
We'll talk afterwards.
I left a message.
What's that?
I left a message. You don't get it?
Maybe you didn't leave it to my phone. Hello there. We'll talk afterwards.
Please.
Hello. Hey, how you doing?
Getting back.
All right. Hello, everyone. Oh, not yet. Okay, we're recording this, so he said, hold up. All right. We're not ready for the tip-off. Okay, good afternoon, everyone.
Good afternoon.
Thank you all for joining us. I see a lot of friendly faces out there in the audience, and some of our staff and some of our friendly community folks and some new faces. So we're very pleased to continue this series, this Lunch and Learn series, featuring a number of our clinical leaders at the hospital to discuss issues and clinical aspects of their respective disciplines. This month is Oncology Month, and we're very pleased to present to you today an oncology lecture, and I'll introduce our speaker in a minute. We also are streaming this, so we will be recording and streaming this presentation through Facebook, and we're very pleased to extend this lecture out there to the internet world. So just a quick little news brief there. We are probably about a week or so away from finally getting our emergency room going, and we're very excited about that project. We've been doing lots of redesign work and making sure that we have the absolute best possible design and facility that we will now make available to our community. And so we're very excited that that will be starting over the next week to 2 weeks. And we anticipate that project taking about 18 to 20 months. So you'll be hearing more about that. That will be a 35,000 square foot new emergency department. And on top of that emergency department will be the home of new operating suites, which will be part 2 of our project, phase 2 of our project, which will be an expansion of all the peri-op office and support space, in addition to 8 to 10 new ORs. So very excited about the plans that we are now launching. We'll also be starting probably in late summer a cogeneration plant, which will be timed with the opening of the new emergency room. So this new cogeneration plant will allow us to actually produce our own electric through 2 gas turbines and actually allow us to come off the grid. A great savings, not only from a utility standpoint, but more importantly, a great environmental change for us here at the hospital. And so thinking green and doing things that are more environmentally friendly, that is at the top of our list here at Richmond University Medical Center. So without further ado, let me introduce our speaker, someone who's relatively new to our team. Very, very pleased, I have to tell you. He is a tremendous addition to this hospital. He came on board just a short while ago, and Dr. Shulimovich is a triple boarded, not single boarded, triple boarded oncologist in internal medicine boarded, hematology boarded, and medical oncology boarded. So I'm very, very excited with a lot of our new additions who are, one of the things we pride ourselves in here at Richmond University Medical Center is having an outstanding medical staff and building on the great foundation that we have and beginning to recruit new leaders to join our team. So Dr. Shulimovich comes from, he did his residency at Beth Israel, and he also did his training at Mount Sinai, and he did his fellowship at Maimonides. So he has been in our local community, training at some good organizations, and now he is with us full-time as a faculty member and someone who I have to tell you on a professional level and on a personal level, we couldn't have picked a better guy. So welcome, Dr. Shulimovich.
Thank you. Hi, how are you? Thank you for that introduction. Appreciate it. My name is Max Shulimovich. I'm a hematologist oncologist here at Ramsey. So today we'll be talking about sort of a very general but overview of how to treat cancer. There's a lot to discuss, and it's hard to squeeze it in to one lecture. As you can imagine, it's generations of research went into every part of this. So it is hard to really squeeze it in, but we'll try to give an overview. Just in general, what is cancer? What is cancer? So a cancer is a series of mutations that happens in a normal cell that results in that cell's transformation into a cell that doesn't want to die, like normal cells do. Normal cells live and they die, live and they're replaced, like everything else. And these cells are mutated. They now grow, divide, and they don't want to die. And that's an important concept, that a cancer is a mutation of a normal cell. And that mutation, it leads to the change in the cell, the change in the cell cycle is now dysregulated. It is no longer dividing and growing in a normal pattern. It is evading growth suppressors, meaning it keeps growing. And it doesn't go through a process called apoptosis. But what makes it very difficult to treat is that it does come from a normal cell. So you can imagine, when you're trying to destroy a cell that stems from a normal cell, you may in fact destroy normal cells. That's a very important thing, and part of the reason why cancer is so difficult to treat. Plus, because there are these mutations, the cancer doesn't stop mutating, it keeps mutating. Meaning as you give it treatment, it mutates, it changes into a cell that doesn't want to die from the treatment you give it. It mutates again, it changes, it grows, it adapts. So, the only real way to achieve any sort of a success in treatment of cancer is to get together. So it's called a multidisciplinary approach, where very different fields in oncology meet together and come up with the best way to treat a patient. Now, there are three major fields in oncology: surgery, radiation oncology, and medical oncology. I'm a medical oncologist, meaning I treat with systemic therapy, the therapy that would go either in a vein or a pill. So, and the major therapies are chemotherapy, which you guys have all probably heard about, targeted therapy, which you may not have heard about, and immunotherapy, which is very new. So I'll be discussing some of the old treatments, but I'll focus on the new treatments in oncology, the exciting new developments in the field of medical oncology. We give treatment systemically in order to, in a few different ways. One, after surgery, it's called adjuvant, in order to decrease the chances of the cancer coming back. Prior to surgery, when we want to decrease the surgery, make the tumor smaller prior to surgery, so that there is less of it to take out and the surgery is easier to tolerate. 3, curative. Some cancers we can cure just with IV treatments, lymphomas, but others as well. We can cure them entirely just with IV treatments, or palliatively. Unfortunately, in some situations, we cannot cure certain stages of certain cancers, but we can still treat. But why do we treat them? Well, we can extend their quality of life, meaning cancer can cause symptoms, obviously pain, but as well as others. And treating it may decrease those symptoms. 1, and 2, extend their life. Now, even if you cannot cure them, you can extend their life. And at times, you can extend their life tremendously. Particularly targeted therapy, hormonal therapy. You can buy patients, not sometimes, not months, not years, but sometimes decades. And that's a very important part of treatment in a setting where you cannot cure. They can benefit, and sometimes for years and years in certain situations. But unfortunately not at all, in all. Now I'll discuss the treatments that I have mentioned: the chemotherapy, targeted therapy, and immunotherapy. Chemotherapy. What's chemotherapy? Well, chemotherapy is a medication. It is usually, but not always, IV, that affects the cell cycle, the normal cycle. So the normal cycle, the cell, it lives, divides, and dies. That's the normal cell. All cells do this in our body. Some cells do it faster. Some do it slower. The faster the cell is dividing, the easier it will be to kill with a medication that inhibits the cell cycle. And that's what chemotherapy is in general. All chemotherapy is that. You try to affect the cell cycle at different points of it, thus preferentially destroying the cells that are dividing quickly, like cancer. Sparing cells that divide more slowly, like most of our body cells. But not all. There are cells in our body that are dividing quickly. Blood cells, hair grows, nails grow, right? Cells that are growing and dividing constantly divide quicker. So those cells are preferentially affected, thus with a side effect. So if the blood cells that divide very quickly, that are, they live, they die, and are replaced in our body, if they're affected, then the white cell would go down. It's a common side effect. Mucositis, because the endothelial, the lining of all our tracts, so the GI tract in particular, it divides and is replaced. That is affected preferentially. Thus, there are a lot of side effects that you may have heard with chemotherapy. Mucositis, inflammation of the mucous membrane, loss of hair, nausea, infections because the white cells are very low. It can be a toxic treatment. But the benefit of chemotherapy should not be understated. Most patients do tolerate it very well. Even if they develop side effects, we treat the side effects. Patients improve. And there's a tremendous benefit in certain situations. This is a chart where they have compiled different clinical trials to assess the average risk of the cancer returning, of being cured of breast cancer in this case, and the benefit of chemotherapy. You could say this is an average. Some have more of a benefit, some have less. That if patients, 10 patients, have only surgery, then 6 of them will be cured, let's say. But if you give them chemotherapy after, you're increasing that number to 7. So you save 1 person for every 10 patients who are receiving chemotherapy. Now that's a very solid benefit. It means with the cancer like breast cancer, it's a common cancer. You're saving a life every time you treat 10 patients. And that's an important, very important benefit. And it's an average benefit, meaning there are some you really needed more and some needed less. In certain situations, when there's a very high risk cancer, chemotherapy alone isn't enough. So there are other therapies, like targeted therapies, and we'll talk about them in a second. Here you can say it's a really risky breast cancer, and chemotherapy alone adds about 10%, 13. But then you could add 10 more with targeted therapy called hormonal therapy, and more with another targeted therapy called trastuzumab. Thus, you are doubling this patient's survival from 30% to 66%. You more than double their survival. Again, you're saving 3 lives for every 10 patients you treat in this case. So it's an important benefit. So even though there are side effects, we're becoming better and better in managing the side effects. And chemotherapy saves lives. Now, what is targeted therapy? So there's a lot to discuss about targeted therapy. It became big about 20 years ago, and there are multiple clinical trials and lecture series and courses. It saves life. Alone with chemotherapy, you can cure certain things like lymphoma or leukemia with targeted therapy. But the best way, I think, I will focus from now on in this lecture on management of metastatic lung cancer and the new developments in targeted therapy in that setting. So this is only the cancer that we cannot cure, unfortunately. We can treat, as I discussed, but we cannot cure. So I will focus on that in this setting. So what's targeted therapy? Well, what they found out is that if you find the mutation that has caused that cancer to transform, if you find it, and you find a drug that can affect that mutation, you can kill that cell. You can kill that cell. You find the target, which is that mutation that caused the transformation of the cancer cell, and you target it with a drug. You will kill that cancer cell. That is targeted therapy. That's another, so there are a lot of drugs. This is mostly for the doctors in the room, that there are pathways. Driver mutation is what it's called, the driver mutation pathway, the pathway that drove that cell transformation into malignant cells. And you can, if you affect that pathway at any point, the cell may die. And in the first trials, it was quite an impressive thing. This is the about 10-year-old phase 1 trial. You can see a chest X-ray. Now, although the dark patches are air, that's what the lung is supposed to look like. Dark. Here you see the white patches everywhere, right? That's not normal. That's cancer in this case. It's all cancer. Incurable lung cancer. And then they found out if you give this patient the drug, and if you notice, that's on day 1. If you give the patient a drug, this is on day 5. It's gone. And at that point, they knew they're on to something. They knew that this is, they thought at the time, was the future of medicine. However, a couple more points. So, and they noticed that refractory disease was not likely, meaning most patients with the right mutation benefited. This is the waterfall plot. It just means that almost everyone had benefited if they had the right mutation. But, as we discussed, the cancer keeps mutating. And if you see here, in the end of these curves, unfortunately, after about a year of benefit, which is a lot in that cancer, everyone recurred. Everyone, unfortunately, the cancer changed and came back. It learned a way to evade the treatment, unfortunately. So you can see the end of the curve is 0. So you can see that it slowly goes down to 0. Yes, it takes longer. Yes, they live longer, clearly. But eventually, they all die of their disease. There are new things they're trying to do. But they're trying to, well, let's make the targeted therapy drugs stronger and better. And this is the latest one. This is just came out in 2018. Another year. So there are drugs that are better that give them another year when compared to the other drugs from a few years back. So an extra year. Yes, they live, again, an extra year longer. So it's now 2 years of a disease that most patients would die within months from a few years back. Now they live another year. But still, eventually, unfortunately, the cancer learns how to evade the treatment. It mutates again. And it comes to the other part of the lecture, immunotherapy. Now that's the latest in oncology, in medical oncology. What's immunotherapy? Well, so they started thinking a different way. Let's say, okay, so the targeted therapy, it works, but still the cancer learns how to evade it. Let's go another way. How else? Well, they found out that the cancer had evolved and mutated to inhibit the body's immune response to itself. It finds ways to evade the immune system. And pretend I'm just a regular cell. Don't kill me. That's what it does. It mutated to evade the immune system. And they found out exactly how it did that. There's a receptor that is expressed on its surface. There's a few, but the main one is PDL1. It expresses PDL1 on its surface. And when that meets the PD1 on the T cell, that T cell, which is an immune cell, is inhibited. So they thought, what if we inhibit the inhibition of the immune system, allowing the immune system to destroy it? That's immunotherapy. That's a checkpoint inhibitors that some of you may have heard of. And this is really its claim to fame, and this is important to understand. This is the early trial. We have better trials that I will talk about it in a second, but this is the early trials. Immunotherapy, unfortunately, really only benefit in this case, only about 20% of patients. Not a lot, 2 out of 10. But you should notice the tail end of the curve, the very end of the curve. The patients who benefited continued to benefit. The cancer couldn't figure out how to evade that treatment. That benefit had lasted. And the trial ended, and the patients were alive. And they followed up in some years, and patients were alive. The way that immunotherapy is destroying cancer cells, the cancer has trouble evading. And that is really its key to success. That's why the idea had won the Nobel Prize. It's a fascinating thing. So now, how do we make it more than 20%? And that's really all the research at the moment. How do we make it more than 20%? How can we make it true for everyone? One more thing about it. What they noticed also is that unlike chemotherapy, it is a lot less toxic. Immunotherapy. Chemotherapy, we said it affects normal cells. Immunotherapy may have toxicities, and often does. They're usually mild. People have a rash. People have a little bit of, sometimes they can have a little upset stomach. But the side effects are usually mild. And the serious side effects are only about 25%, which again we treat and most patients recover, but it's a lot less with chemotherapy. So it's a treatment that's more effective and a lot less toxic. So again, so there are new things you could do to try to increase that to more than 20%. What can you do? Well, maybe you can select the right patients. Maybe we should give it to everyone, but only select the patients who would benefit. So there's something called PDL1 expression, and I found if you select the right patients who have high expression of PDL1, you will find that now it's not the 20% of the benefit, it's 40%. You're doubling it. That's one thing they did. But if you combine different immunotherapy agents, same thing. Now that's for everyone. You're doubling it again, from 20 to 40. Again, very encouraging. What if you combine with chemotherapy? Now that's more toxic, as you can imagine. But the benefit, again, you benefit more people. About 35%. All of these treatments are available with us. We have a multidisciplinary approach to every cancer patient, where we all meet at tumor boards. We have GYN tumor board, we have a breast tumor board, and we have a general tumor board. We have all the latest treatments and we know about them. We have excellent staff of oncologists. We work together to treat cancer. Now, I'm a medical oncologist, but I'll talk about the other fields of oncology that we offer in the Cancer Center. Radiation oncology with Dr. Lee and Dr. Adams. We have incredible capabilities in there. Now, radiation, also, what's radiation? Well, you shoot light, radiation, at a tumor, and you cause DNA damage in the tumor. Again, affecting the cell cycle. The cells that divide the quickest die preferentially. But, as you can imagine, there's a lot of normal tissue in the way. So the new, latest equipment figured out a way to spare most normal tissue. Now, it's a complicated thing, but and I'm no expert because I'm a medical oncologist, but the vectors are rotated around the body and they meet at the point of the tumor, sparing the rest of the body from the high dose of radiation. That's SBRT, and that's what Dr. Lee and Dr. Adams do at our Center for Cancer Care. Now, this also idea that they do imaging every day because the tumor gets smaller and you need to adjust the radiation field in order to, again, to spare normal tissue, to do as little damage as possible while still killing most of the cancer. And that's what they do there too. And you can see the tumor, in this case, shrinking every day as you give radiation. We have a new pathology department with Dr. Barber, Dr. Sun, and Dr. Zong. There's just formed here at Rumsey. Excellent turnaround time. We do things fast. We do things efficiently. That's about it. Thank you. Now I'll take questions. Yes, please.
Yes, I heard about proton therapy. What is that about?
So it's a type of radiation therapy that may be useful in certain cases that is a question for a radiation oncologist. We don't use it here to a great degree, but mostly because it doesn't usually work as well as other forms of radiation that we have. Yeah.
President Carter, he was healed of, I think, stage 4 brain cancer. What treatment did he have?
I'm not familiar with that case, I'm afraid. Yeah, I don't know what kind. Stage 4 brain cancer is an odd thing because it is usually, brain cancer usually doesn't metastasize, it stays in the brain. Unless it was stage 4 to the brain from another organ, and I'm not sure what type of cancer President Carter had. Yeah. Yes?
Are there any new ways to determine who the right patient is in addition to the PDL, as you mentioned before?
There are things called, they're studying multiple ways, but the big one now is a mutation burden. You sequence the genome, basically, of the tumor, and the more mutations they have, the more likely they are to benefit from immunotherapy. The more likely the immune system is to recognize the cell as other and destroy it. So that's the big one now. So you do next gene sequencing, and if you find multiple mutation, they call it high tumor mutation burden, they're more likely to benefit. Even better perhaps than PD-L1 expression.
Thank you.
Yes.
Are there any specific foods that cause cancer, or is it more of a genetic issue?
There are definitely foods that cause cancer. There's a lot you can find on it from the CDC, and so processed meat, red meat, are the classic ones. Yeah, but there's a lot of food that can cause cancer. The risk, the absolute risk increase is small, but clear. Yes.
Hi, I see on the screen the 3 different treatments.
One more time.
3 different treatments for the cancer.
Okay.
Which one is work better?
It depends on the cancer. So some cancers don't work, some treatments don't work, and others do. It's a very specific decision, and it's pretty much what we do for a living, is deciding that point. Which treatment works best, when to give it. Now, there's also different types of chemotherapy. There's not one chemotherapy, so we pick which drugs are best, which immunotherapy also, which targeted therapy.
So, because my daughter-in-law, she's 49 years old, and she has a stage 4 cancer. And she jumped.
What kind of cancer?
She had in the breast, now she's spread all over. So, it's very bad. So, she had a chemotherapy, they stopped her, and they started a new one. So, we don't know what's gonna happen. I invited her today to come here, but she doesn't feel good. We hold relapse sessions. It affects the whole member of the family.
I'm sorry.
It's bad. She's beautiful, 49 years old with the 4 children, and we were devastated. So that's my question, which is best the treatment for her, because if the chemotherapy doesn't work anymore, they stop it. I think now they started the immunization, the way you...
Immuno, perhaps, yeah. So she can come for a second opinion if the decision is involved.
I have a 10 opinion.
Okay, so it's hard to do this just like this because it's a very involved decision. It depends what she had. It depends where it's spread. It depends how strong she is. So she can come for a second opinion or a third or fourth, and but it's hard to say just like that. I can say breast cancer, metastatic breast cancer, when it has spread to other organs, it is unfortunately likely incurable. But there are again new developments that she may benefit from. And whether she benefits, it depends on certain factors that it would be hard to decide without knowing them.
In the breast.
I'm sorry?
She had the breast cancer 5-6 years ago.
Uh-huh.
She was free, now come back again.
Right. Unfortunately,
She
that's
had
a
already operation in the stomach. She had all over in the stomach. It was really, really, we better upset about that.
Yeah, I'm so sorry. Yeah.
So, but thank you.
No problem. Yeah. Go ahead. Yes.
Me?
Yes.
Yes, doctor. How can we prevent cancer?
That's $1 million question. You know, so we know certain things cause cancer. Smoking. Don't smoke would be one. Eat right. Exercise. Those things we know make it less likely, but it doesn't eliminate your risk. I hear that argument all the time. Oh, why do you say that smoking causes cancer? I have a grandfather who smoked and didn't die from cancer. I hear that argument probably at least twice a week.
What about the environment? I mean, look at all these tires that wear out, all that rubber that disintegrates. It's all
The rubber.
Is that affecting us?
I'm not familiar with that, but
Environment.
there are definitely environmental factors that affect cancer. The classic example is sun and melanoma, an exposure to sun, radiation in the environment, an exposure to radiation. There are definitely factors that in the environment, in the foods you eat, as well as your genetic predisposition, that in certain cases make it more or less likely to develop cancer. And there are a lot of factors. And they're not absolute, meaning, so just to continue that thought process of why do you say smoking causes cancer if I have a grandfather that smoked and didn't die from cancer? It's kind of like playing the Russian roulette, I always say. You know what a Russian roulette is? You take a gun with one bullet and you spin. There's only one bullet. There are 5 others that have no bullets, and you shoot. And just because you didn't die doesn't mean it was a very good idea to play. And that's the argument. That it clearly increases your risk of cancer. Yeah, good.
I'm Dr. Lena Merlino. My sister, Dr. Ann Merlino, she's PhD, MD. Okay. She was dean at the College of Staten Island. They did a lot of research there. However, she was chair of the American Cancer Society for many, many years. And they were very instrumental in trying to educate the public on the dangers of smoking. In fact, she even went down to Washington, D.C., because they were voting on trying not to get these little delis near the high schools to have cigarettes and to get them away from there. And there's no doubt about it. I don't know if anybody here smokes, but there's no doubt about it. That in spite of, I used to have my patients, I do pediatrics and adolescent medicine, and the mothers would come in with their 12, 13, and would tell my son not to smoke, but yet the mother was a heavy smoker. And so the boy, I said, well, I can't tell him really not to do anything, but I can explain the dangers of smoking. And they have an answer for everything, teenagers. Says, well, look at all the environmental things, the deductible, blah, blah. I says, wait a second now. You have a choice of whether you could smoke or not smoke. You have no choice about the environment. We still have to live in there. But they still, and the statistics, I don't have to tell you, doctor, is so high that if you start smoking at 12 or 13, and most of the smokers are, if they start in their early years, they're more likely, of course, to develop cancer, okay? The other thing is that there are so many children, I see them on the street corner still smoking. And adults, I see them outside the hospital here still smoking, you know. It's a habit like anything else, whether it's an addiction, I don't know, but
it is.
But it has to be an addiction. It's very difficult, because I have some family friends who were heavy smokers, okay? And all of them had cancer as well. So
Right.
I think there's a different relationship, of course.
Absolutely. Go ahead.
Yeah, when people get cancer on Staten Island, you often hear, well, you should go to the city, you should go to Sloan, what are the arguments to staying here on Staten Island at a hospital like yours?
Excellent question. So you have to ask yourself, what will you get by going to the city? I mean, and there are some things sometimes. Most of the time, the treatment you will have there will be the same treatment you'll receive here. What these big places have sometimes that we don't have is access to clinical trials. So the medications that are not available to the public, that are being studied, which may be better than a standard of care, or maybe worse. That's the point of a study, right? To decide. So that's what they have. Some patients, some situations that are not clear-cut, we send for a second opinion to Sloan Kettering, which usually confirms our first opinion, and we treat here. So the argument to stay is that you will not get, most likely, different treatment. One argument. Two, the care there usually is impersonal. You don't know your doctor. You see a different doctor often, every time. Our center is on the small side. You can call us 24 hours a day, 7 days a week, and you can talk to us. You can ask questions. We'll spend time talking to you and explaining. Unlike them. And if we need them, we'll ask them.
Is there any evidence about a person's personality, their sense of well-being?
Stress.
No, I'm trying to think of the right word. I can't, but I mean, if a person is depressed and unhappy, that's one thing. Can that contribute, as opposed to a person who is not depressed, has a very positive outlook on life and is optimistic and things like that? Is that an element in the development or the treatment?
Are you asking whether that causes cancer, or whether we can consider that when we see patients?
Both ways.
Okay.
Is somebody who has a very positive outlook less likely to develop it, as opposed to a person who's depressed or something like that? But once they do develop it, how will those different types of personality affect?
Right. As far as I know, there is no clear evidence. Now, everything we do in medicine, what I showed you, the graphs mostly and the charts, is based on clinical trials, meaning they were done prior. 2 arms, they took patients in one arm, they gave them this treatment, and another arm, another treatment, and see who lived longer, who did better. Okay? Everything we do is evidence, is based on evidence. As far as I know, there is no clear evidence that shows that better outlook means you are less likely to develop cancer. We contribute, when we see patients, that's part of the review of systems, we call it. We talk about it, and it is an important part of patients being able to complete treatment sometimes, their psychiatric well-being. We have means to refer to specialists in that area. So we do think about it. But as far as I know, stress, there's some evidence, although not very good evidence, that stress contributes to cancer. But there's no clear evidence, as far as I know, that sort of this happy people are less likely than sad people to develop cancer.
Or deal with it when they're being treated?
Dealing with it, so depressed people, so clinically depressed people have trouble dealing with everything, including cancer. Yeah, that's sort of that's the definition. They're depressed.
Mm-hmm.
So we do advise treatment, but of psychiatric illness, of any kind. But yeah, certainly intuitively, I would say that probably yes. Probably, being sad makes it more difficult to tolerate anything. But I think it would be true.
Mm-hmm.
I'm not familiar with evidence that shows this. Yeah, go ahead. Yeah.
I had colon cancer and I'm in remission now.
Good.
And number one is remission good. Number two is that there's such a high rate every day. In fact, I have a good friend who just passed away with colon cancer spread to the brain, to the liver. And why did that happen so fast? And why is there such a high rate? But it's that particular one on Staten Island. That was just one case, but there's several cases. My mother works at OPS 57, which has parents that have the same thing that I have colon cancer. It's just all over the place, and it's that particular one. It just seems like there's like a high rate in Staten Island.
There is a higher rate of cancers, not just colon cancer, particularly thyroid cancer, but more than one cancer in Staten Island than other boroughs and other places in the U.S. There's a task force that's trying to figure out why. There's no easy answer. I don't know why. But colon cancer, you asked the first part, being in remission certainly is a very good thing, yes. The longer the remission is, the less likely it is to come back. But there's a high risk rate, and there's a lot of theories to why that's the case, and they have a task force right now trying to figure that out. It's a complicated question. Yeah.
That's true in Germany.
I'm sorry?
In Germany.
In Germany,
they told they have a treatment they're not allowed here in this country. That's true?
I don't know. I'm not sure. I'm not sure which treatment. The
Cancer.
The cancer treatment. Yeah. So I'm not sure which treatment they have in Germany. That would I'm not sure. I would say that almost everything that has been proven to work, we have here in the States. We have a very, how should I say it, wealthy healthcare system. We have great places like Sloan Kettering Brothers, MD Anderson, that does incredible work. If it's not here, there's a reason for it.
The government is not allowed. That's
The government doesn't randomly not allow. There's a reason for it. There are different treatments that are experimental, that are more likely to harm sometimes than help. There is a reason for it usually.
I think I'm satisfied with the United States because I see people come all over the world here. So
Right.
what's the difference to go to Germany? That's what they told my daughter to go to
To Germany. What's the name of the treatment? Do you
What?
what's the treatment called? Do you know?
I don't know. See, I don't want to get involved too much because I get nervous.
Gotcha.
And I don't want to have the question behind I have to
I
my son.
understand. I understand.
But we get very upset about this.
I know. I'm
That's what
sorry.
I'm talking
Yeah.
about.
Yeah. Go ahead.
Stem cell therapy,
Yes.
I hear a lot they're working on that. Does that have any
Being researched.
possible
Yeah.
benefit for cancer
C-
patients?
certain cancers, it is used. There is stem cell transplant in leukemias and certain lymphomas, certain cases that is used now. Everywhere, it's experimental, meaning that it might be something that will be treatment of the future, or like majority of things that are tested, it will fall because it will be proven not to be effective, or not as effective as they thought, not more effective than the standard of care that already exists. So it is experimental.
Is it more aggressive in the young person of the cancer or the older one?
It is more what?
Aggressive.
Aggressive.
Is the young age or old?
Older age is always a risk factor. Being older is always worse with the same cancer, because it is harder to treat older people. We treat, and what is old or what is older keeps changing. People live longer, people are healthier, they can handle more treatment. But in almost across the board, the older they are, the more difficult they are to treat. Meaning, unfortunately, the more difficult they are to cure.
And I believe in that, so
Okay.
thank you.
Yes.
Well, I have another question. This
Sure.
is a spiritual aspect. People who have practiced some religion or spirituality, is the percentage of cure or higher than?
You know, I saw that the truth is that, much like your question, we don't have evidence for this, but I saw a clinical trial some time ago. It wasn't very well done, the clinical trial. It was a very small clinical trial. But it took patients who were being prayed for and followed them, and compared it to patients who are not being prayed for and followed them, and found a small benefit. So patients who were being prayed for did a little better. It was not a very well done trial. It was mostly an observation, and it might just be a coincidence. But that, you know, but that, I did see that clinical trial at some years ago. It is not something that is being well studied at this time.
Okay.
Yeah.
So young people have a more hope to survive with the cancer.
Yes, as a rule, yes. But unfortunately, it isn't always the case.
So nobody knows how the aggressive cancer is coming from. Nobody knows.
Well, we know certain things about cancer, but we don't have all the answers. We cannot cure every single patient, unfortunately.
Why? Because sometimes it's too late. They caught too late.
It is definitely, if the higher the stage of a cancer, the more difficult it is to cure. It is also, as I mentioned, the cancer keeps changing, mutating, and trying to avoid the treatments. Yes.
Countries. What countries have very little cancer, and like I think Japan has very little, or?
Japan and Asia has a very high risk of gastric cancer, higher than us,
Really?
certainly in Europe. Developed world has less cancer than underdeveloped world. So particularly when it comes to cervical cancer because of screening, but others as well. So it depends on the cancer. We don't know, in some cases we do, meaning they smoke more in certain countries. So we know, sometimes we know the association, and sometimes we don't. Like in the gastric cancer, there are a lot of theories why it's more prevalent in Japan, in China, and Korea, but we don't know exactly why. So it depends on the cancer, but as a rule, developed world has fewer cancers than underdeveloped world. And you're more likely to survive a cancer in the developed world. Yes.
Thank you very much.
Go ahead.
You mentioned with the immunotherapy that the idea was to trick the cancer so that the immune system would be able to attack it and destroy it.
Yes.
So it seems to me that the answer to the overcoming of all cancers is for the immune system to be able to deal with and destroy cancer.
Possibly, we're hoping. There are other now more interesting immunotherapies that are being developed. One of that is called CAR T cell therapy, where patients' immune cells, called T cells, are extracted. So you give you blood and they're spinned out. They're sent to a lab where they're taught to recognize a particular cancer. They're expanded and reinfused into the patient. And that is something that is available in certain cancers now, but we're hoping will be available in a lot more. It's called CAR T cell therapy, if you want to read about it.
C-cell?
CAR T cell.
CAR T-cell.
Yeah.
And that's for most types of cancer?
At this time, it's only for ALL, which is a specific type of a leukemia, and specific type of lymphoma, called large B-cell lymphoma. But they're trying to expand it to all sorts of areas. There's a lot of research in that field at this time.
Good luck.
Thanks.
Thank you.
Everything we do in medicine is based on clinical trials that show that meaning there's a clinical trial, like the one that I showed you. Good clinical trials for herbal therapy don't exist. They have some, but they're not well developed, they're not reliable. Whereas you can do herbal therapy, perhaps in certain cases, in conjunction with mainstay treatment. Definitely don't recommend it instead of treatment that we have evidence works. A lot of them, a lot of treatments that they have, herbs are trying to sell you, are likely of no benefit. Likely.